Good afternoon, everyone, and thank you very much for joining us in our last autumn health seminar, which is organized by the Center of Primary Health and Social Care at the School of Social Sciences and Professions. My name is Yolanda Eraso. I'm Professor of Health Studies and Director of the Center. So I'm very pleased to introduce our speakers today, who are from the Division of Population Health, Health Services Research and Primary Care at the University of Manchester, Dr. Igor Francetic and Dr. Sharon Spooner. A warm welcome to you both. Dr. Francetic, he's a research fellow, an applied economist working on health and healthcare. His previous research work includes cancer detection and screening services, inequalities and inequities in emergency care, and the primary care workforce. And Dr. Sharon Spooner is a clinical lecturer, and her main areas of research are primary care health workers, on which she has explored different dimensions of the roles, training and recruitment in relation to changes in health system organization. So Dr. on the project that will be presented today, which is an investigation of the scale, scope, and impact of skill mix changes in primary care, which is funded by the National Institute of Health Research. So the seminar today will address changes in general practices in the introduction of new roles, including social prescribers, clinical pharmacists, paramedics, and some other roles. These new roles, as you probably know, were introduced to tackle the shortages in GPs and nurses in general practices. And their presentation will explore the impact on quality outcomes that follow the introduction of skill mix changes in practices. So we will have time for question and answer at the end of the presentation, and I'll encourage the audience to use the chat box as we go along. Please do, so we can get back to those questions at the time for discussion. Finally, just to let everyone know that the session is being recorded and that the video will be uploaded to our Center for Primary Health website. So over to you, Igor and Sharon, please.
Thank you very much. Thanks for inviting us. I will start this first slot of the presentation and then hand over to Sharon for a qualitative exploration, which is meant to give a bit more depth to the quantitative results, which I will present. So Yolanda had a fantastic introduction there, so there's no need for me to spend more time here. What I will present is, what I will try to do is to walk you through the results and methods before the results of a paper that was published this year in Social Science and Medicine. And the title is, again, Skill Mix Change and Outcomes in Primary Care. And this was a longitudinal analysis of a large sample of general practices in England between 2015 and 2019. So this is just say, I'll try to walk you through these results, and then Sharon will give you an in-depth overview of what we think the mechanisms are behind these results. But if you want to know more and more details, you are very free to go and have a look at the paper. So this is not just my work. This is work of a team of people. Specifically on the paper, there was contribution by a few co-authors, which are listed here: John Gibson, Sharon Spooner, Kat Checkland, Matt Sutton. The broader project where this paper is, which was a bigger overarching framework, and this project was just one little bit of that, involved more people than the co-author of this paper. And Sharon Spooner actually was, again, the PI of this broader project funded by the NIHR. And nevertheless, what we will tell you here, it's our opinion and not the opinion of the NIHR or the Department of Health and Social Care. So with this out of the way, I guess I can start by stating the obvious, which is no one here will be surprised by the workforce crisis that is affecting the NHS. There's a huge shortage of GPs, nurses, and also other support staff. This is due to, even before suffering of a shortage, there's a failure to recruit people. Then those that are in the profession tend to go out of the profession, so there's a poor retention of these people, and that's coupled with very strong budget pressures and sort of a push to shift care to community settings because of these budget pressures and because of other needs. On top of all this, which was already there, we had something called COVID, which we all know about. So this workforce crisis means the staff which is working needs to bear increased workload, which has many consequences on quality of care, on the mental health of the staff themselves, again on retention, and all this again is happening at a time where the population care needs are changing because of aging and an epidemiological transition happening decade after decade. So what skill mix change is, or how we try to think about it, is that skill mix is simply a way to get around these shortages. If you cannot have a GP practice fully staffed with GPs and nurses, or these more traditional roles, let's try to add new roles which are maybe easier to train and to get and complement the work of GPs and nurses in primary care settings. So this also means that our way of conceptualizing skill mix adaptation and skill mix change is simply, to some extent, as an expansion in the employment of these new non-traditional roles. So just expanding the number of people working in primary care that are not part of the two main traditional roles that are GPs and nurses in primary care. Crucially, this is not a strategy that's unique to England. It's something that's happening worldwide, essentially. One thing that we found when working on this larger, broader skill mix project is that surprisingly, the evidence is not so clear and not so rich. And on top of not being much, the existing evidence is also, to some extent, weak because it's based on cross-sectional analysis. And now what I'm referring to here is quantitative evidence. So studies looking at statistical association between skill mix and some measures of primary care outcomes are mostly, not only, but mostly based on cross-sectional analysis, which are more prone essentially to all sorts of biases in the estimates. Now, focusing on England, this is what skill mix change looks like, or looked like to us when we approach this issue. Specifically, what you can probably see if it is big enough is that GP partners have been shrinking over time. Now this, notice this is 2015 to 2019, so this is a fairly short time period, but we can see that GP partners are decreasing more and more, and Sharon Spooner will know more about this probably. Salaried GPs are a little bit increasing, but they are fairly stable. And what's really happening is that these new roles, which are those essentially on the far right of the plot, are getting like slightly bigger year after year. The biggest change that you can probably observe is in the pharmacists on the one hand, and well, healthcare associates, HCAs, have been increasing a little bit. And so this graph was supposed to say, well, we see that clearly there's a shrinkage in the traditional role and a slight increase in the non-traditional roles, although these changes in non-traditional roles are small, but they are happening. And all this is up until 2019. After 2019, what really happened is that in England, there's been the rollout of PCNs, which have a dedicated problem to improve and increase the availability of additional roles, which means that these bars will be even larger after 2019. But what we discussed today is only related to the pre-PCN period, essentially. So this is stuff that happened over a 5-year period before PCNs were implemented. And we were trying to see whether we can find some dynamics in the data that suggest what including these additional roles means for primary care outcomes. Yeah, exactly. So our research question for this paper was, what are the implications of these skill mix changes for primary care outcomes? Probably going back to something I said a couple of slides ago, the way we tried to operationalize the idea of skill mix was the number of staff employed by GP practices. So our main exposure in this study was the practice level full-time equivalent staff in different staff groups. Now, the NHS provides a very detailed level of data in terms of staffing. Problem is, if we go too deep, the changes and the numbers are very small. So we had to aggregate stuff up to a meaningful level, which was meaningful both for interpretation and for statistical analysis. So what we ended up doing was to aggregate the staff groups into these 4 large groups that are based on a WHO staff grouping. Just we wanted to rely on something that was already out there, and we use the WHO classification. So the main group, classic group, is that of GPs, which includes partner GPs, salaried GPs, and locums. Then we got a big group of nurses, both standard nurses and advanced practice nurses and specialist nurses. And then we've got these 2 large categories, which include the non-traditional roles for primary care. Healthcare professionals, I will not list all of them, but you can read them there, and healthcare associate professional. The big difference between healthcare professional and healthcare associate professional is that healthcare professional, HPs, have a direct clinical role in relation to patients, whereas healthcare associate professionals are more in a supporting role compared to healthcare professionals. Now, this aggregation, we did not fully expect this, but this aggregation and naming certain staff groups is somewhat sensitive. So these are just a few extracts from an email that I got after the paper came out, essentially saying that, well, somebody was very disappointed that the role of physician associate was categorized under a non-medical role. So I guess every category has the interest in claiming their space in the primary care landscape, and that's fine. The only thing I can say that what we did was to aggregate according to the WHO classification, because we needed some meaningful labels, but also some meaningful numbers to estimate. And we were not trying to pick on some specific professional roles. Moving on to the domains that we explored and the outcomes, we have these kind of 4 broad groups. In terms of the structural dimension of primary care, and specifically access, we looked at the average months since the last GP appointment by practice, aggregating and averaging the responses of the GPPS survey for that practice. On the process dimension of quality, if you want, we have the percentage of QOF points achieved at the practice level, the percentage of narrow spectrum antibiotics over all antibiotics prescribed at the practice, and the volume of prescription in terms of items prescribed per 1,000 patients. So in terms of just how much practice is prescribing. Looking at the user experience at the practice, we have 2 indicators, which are the patient experience with making an appointment and the overall patient experience with the latest GP visit. And these again are averaged at the practice level from data from GPPS. Finally, we also look at costs of care, specifically looking at the cost of prescriptions, cost per item prescribed, and the overall NHS expenditure, so payments to the practice from the NHS, and how that changes. So these are the outcomes that we look at. You find more details in the paper if you want, and if something was not clear in this. So we have 2 ingredients now, which is the exposure, the outcomes. A next ingredient of the analysis was to model how production in brackets in primary care happens. I think it's important to think about a conceptual model of this, because otherwise you don't have something like a reference point. So this is sort of an economics way of thinking about things, and economists like to think about firms or organization having some sort of underlying production function, which is an abstract representation of how inputs are mixed in the organization to produce outputs. Now, we know that in primary care, probably more than in many other industries, definitely more than in the industrial sector, the ways inputs are mixed in a GP practice to produce primary care visits is very complex. So it's not straightforward to find the right way to model this. And that's another limitation of most of the existing studies, because most of the existing studies, what they do is that they take the idea of looking at how inputs translate into outputs in primary care, and they simplify this relationship, this production process, with a simple additive linear specification. So they say, well, we assume that an outcome in primary care is just a function of some number of GPs plus some number of nurses plus some number of other staff. And then you estimate a linear regression based on this very specific form of this mixing process. We think that's not really the best way to describe it, and therefore what we did is to take a more flexible specification for the production function, which allows for non-linearities in how the different inputs enter the production process. And we also, very crucially here, we also add interaction terms between the different inputs that we are interested in, namely GPs, nurses, healthcare professionals, and healthcare associate professionals. So this flexible cubic production function, we think, represents better the production process that's happening in primary care, or at least better than what's out there currently in the literature. So once we have this conceptual model, we need to specify an empirical model to estimate what we want to estimate. And this, again, as I said a couple of slides ago, this, we believe it's a small improvement over the current literature, because we are using at least 3 different years to estimate what we want to estimate. In most cases, we use 5 years, so we have a albeit short panel, a longitudinal dimension over time to explore, as well as across different GP practices. So what we did was to standardize the outcomes to a z-score, so that essentially once we estimate our model, we can compare the magnitude of the different coefficients across different outcomes, just to understand, well, is this larger on one outcome compared to another? And we estimate this flexible production function with this cubic polynomial and include these interaction terms. And one thing that we need to remove, or that we want to remove from the equation by estimating it properly, is this term UI, which is a practice-specific error term, which can be essentially biasing the results if you don't take care of it. The way we take care of this potential bias is that by estimating 2 separate models, so 2 separate estimators for this equation. We firstly run a fixed effect within estimator on our empirical specification, essentially looking at changes from year to year, so year after year. And then we also run or rerun the analysis by using a first differences estimator, where what we do there is we take the difference between the first year that we observe a practice and the last year that we observed the practice for. So in most cases, we will have a difference between year 1, 2015, and year 5, 2019, and we observe how changes in the skill mix from 2015 to 2019 affect outcomes changes between 2015 and 2019. Finally, what we do is to report all these results as marginal effects for the median practice. And again, we have these standardized outcomes which allow us to compare the magnitude of the effects across different outcomes. So now we are at the key findings, and something to say first is that we had in our analysis between 3,000 and 6,000 practices, depending on the analysis and depending on the outcome, because some outcomes were not available for some years. The main key finding of the analysis, which was to some extent surprising, if you think about what skill mix change should do in theory, is that we found that the different staff groups contribute independently to the outcomes. So we did not find evidence of interaction on the outcomes in terms of how many FTE of different staff you have. This is surprising because typically you would assume that, I don't know, yeah, let's pick the group that was mentioned in the email, physician associate, you will think that they will either complement or substitute the work of a GP. But interestingly, we do not find that there's very much interaction between the two. They just do different things and without properly interacting in the work on a specific outcome or patient. Another important or interesting finding is that also reassuring for us is that the results are consistent between the two estimation methods that we used, with a bit more power in the first differences analysis, because as you will remember from the graph with the bars, the bar plot, horizontal bars, the changes in the number of these staff groups is typically small, and small changes year after year are less powerful to explore in terms of statistical analysis compared to larger changes, which is what we obtain when we look at the change between 2015 and 2019 in the FD model. Another finding that's not that surprising is that GPs and nurses tend to be associated with better outcomes overall. We didn't find evidence of specific outcomes that are badly affected by adding GPs and or nurses, although I think Sharon will go a little bit more in detail with this. And then another important point is that most of the effects, actually all of the effects, were very, very small in terms of magnitude and size. So we didn't find anything like major changes in outcome related to changes in skill mix and staff. Most of these changing are very, very small, and among these small effects, the largest ones were interestingly associated with health professionals. So this non-traditional group, which has a direct role in relation to patient in terms of clinical decisions, essentially. And in relation to this group, health professionals, what we found is that everything else equal, or everything else that we can control for being equal, adding one additional health professional decreases patient satisfaction on average in the practice. And at the same time, it increases the percentage of narrow spectrum antibiotics prescribed. Well, patient satisfaction, I don't think need to explain what it represents. Just patients seem to be very much less satisfied when there are more health professionals in their GP practice. The percentage of narrow spectrum antibiotics instead is a measure of the quality of prescription, because thinking that we want to avoid antibiotic resistance, we want generally, I mean, I don't need to tell you this because I'm an economist and most of you will be healthcare professionals, or at least by training, but yeah, prescribing narrow spectrum antibiotics is preferable to just prescribing broad spectrum antibiotics. So this increase in the quality of prescriptions looking at antibiotics, we think it is easily explained by the fact that pharmacists are included in this health professionals group. So it makes total sense to us that adding more pharmacists improves how the practice prescribes drugs. So yeah, this seems to be broadly consistent with some novel evidence that's been released very recently regarding nursing teams in hospitals, but that's a different setting and we understand that. So on this note, with these key findings sort of in mind, I will hand over to Sharon, which will give some more context and depth to the results. Thank you.
Thank you very much, Igor. So as Igor has explained, we found that the different configurations of workforce composition are associated with different outcomes. But I want to talk us through now why that might be the case, and largely looking at in what ways do the changes that happen with a more diverse workforce affect how healthcare is delivered in general practice, and therefore would lead to those different outcomes. So I'll start with an overview of how we conducted the qualitative arm of the study, and from our findings move on to focus on a couple of aspects that are particularly relevant to what Igor's been talking about. The working practices that lead to our finding that staff groups contribute independently to outcomes rather than as substitutes or complementary workers, and how does patient experience change with increasing skill mix deployment associated with decreased patient satisfaction. So the focus of our qualitative work was to learn about the context of general practice and how practices were implementing skill mix. So we weren't specifically looking at the outcomes, but we were looking at what changes have been made, how practices work to achieve organizational objectives, how those changes affected the experiences of patients and practitioners. And we did this by recruiting a bunch of practices across England, doing everything we could to recruit practices working in different places with different patient populations, with greater or lesser experience of having practitioner diversity within their workforce. And it's important just to note, as Igor mentioned earlier, that these research visits took place before the disruption of the pandemic and before these practices had really any experience of having staff employed through the PCN additional roles reimbursement scheme. So clearly the context has changed a lot now. So we just need to remember that this was a time before all of those changes came into place. The numbers of our interviews and let me move on. The number of our interviews and observations I have listed as well. I hope you can see that. It's looking rather small on my screen, but basically we looked at the roles that were available within the 5 practices that we went to, and interviewed and observed to try to get under the skin of what exactly was going on. One of the big questions facing practices and patients alike is, what can the newer types of practitioners do to support healthcare? And unsurprisingly, we found that practitioners from different backgrounds, from different health disciplines perhaps, brought different knowledge, different skills, different experience to their work and general practice, and they had kind of different ideas sometimes about what was most important for them to deliver to patients. So when we look more closely, we found that the role competencies that might be described in something like the HEE multi-professional framework for advanced clinical practice, these might be quite clear on paper, but when we talked to people and looked at what they were doing, the role holder competencies were different, because the role holder competencies brought in other things other than qualifications and a competency framework. They brought in the previous experience, the interests, the upskilling, and lots of personal qualities related to the person themselves, rather than just related to what sort of training they might have had. This illustrates to illustrate it using a quote from a physician associate who said, "I have quite high standards for myself," and he knew that there were things that he couldn't do really well, that he needed to improve on, and that some things were not appropriate for him to look at independently, but he needed to understand his own limitations and what was most appropriate in certain conditions. So very much pitching this as, I'm learning a new role, I'm not an expert on everything, and I need to understand that and get the appropriate support when I need it. So the question is, how do we actually use everyone with different skills, different experience to deliver general practice in the best sort of way? Because actually practices have changed in a lot of ways. In the dim and distant past, patients would typically contact the GP practice to arrange an appointment with the GP for almost any health problem. There were specific things that nurses were doing a lot, but other than that, it was a case of the patient would just contact the practice, ask for an appointment, and usually be given an appointment with the GP. Things have clearly changed an awful lot in the recent past. And trying to understand that is really important, because with new roles you need new working practices. And one of the things that we felt was really important was that practices are now looking to categorize and match the patient's problem with what the practitioners can do. So this has got to go right at several levels. The patient needs to be able to explain their problem in a way that the receptionist will then understand what is needed. That clearly can go well, or it can go a little bit awry. The practitioners need to have communicated with the practice about what their competencies are. And so the receptionists, for example, need to have a really good knowledge of what each practitioner can do, and therefore be able to match them up. And then, of course, there needs to be an appointment available at a time that is suitable for the patient with that particular problem. And if that goes well, yes, you'll have hopefully a very successful consultation. But clearly there are lots of things that can go wrong. Patients can sometimes articulate one problem but actually bring three. The problem can turn out to be a lot more serious, a lot more complex than the patient had initially appreciated themselves. We found that practitioners would sometimes find themselves really out of their depth in dealing with problems that had, in theory, been matched to their appointment. Because there is a vast range of conditions presenting in general practice, and because patients usually only see one practitioner, it's really important that the practitioner themselves is aware of any gaps that they might have and know how to address those. But what we found was that GPs were having to spend a lot more time in supervision and support for the members of staff, and this affects their work-life balance. They were getting debrief fatigue. So people were working constantly, supporting everyone through their own lunch break. They wouldn't get to their own clinical work sometimes until late in the day, perhaps looking at results and things, taking laptops home, looking at them after the children had gone to bed, and then sometimes finding that there's something there that they should have actually responded to a lot earlier in the day. So clearly a lot of issues that hadn't been addressed effectively within how practices were working. And it's a real challenge to design in protected time and co-location if either the premises are not quite big enough or there simply isn't any slack within the system. So the other effects of this is new experiences for patients. We did a patient survey with patients at each of the practices that we were visiting, and asked them whether they thought that the person that they had seen was able to effectively deal with their problem. Fortunately, in most cases, 82% of them felt that all the problems had been dealt with. Slightly fewer, 77%, felt they had seen the right practitioner, and for 74%, they said this was their preferred practitioner. However, when we then spoke to people in focus groups, we found there was a backstory to that wasn't quite so wonderful. The new systems were a problem for people. They had to start to navigate a system to gain access to an appointment that they weren't familiar with. New practitioners were a problem. Who are these new practitioners? What can they do? Where do I find information about them? To be honest, we actually searched ourselves to try to find out what the roles were, what they meant, what that meant people could do. And at this stage, bearing in mind it is now 2-3 years ago, we really couldn't find anything online that gave us a coherent story about what patients could expect from different sorts of practitioners. The other major issue was a compromise between waiting a bit longer to see the person that you normally see or seeing someone different, and therefore compromising your continuity of care. Communicating with patients about the new system seemed to be one really good way that some practices had of dealing with it. But it was challenging because some people are not frequent visitors to the practice, so they're not going to see messages on notice boards and so on. Receptionists were key facilitators of information, but that put a lot of pressure on this, as this quote illustrates. It meant that they were the patients kind of understood that receptionists had a really difficult job, and they were trying to deal with people who were often distressed, and so it was quite upsetting for everybody, really. Factors facilitating improving patient experience of skill mix. I think this was quite interesting. One of the things about seeing the physician associate is the fact that if they're not comfortable, you will be referred to a GP, and that's really important for patients to know. So this was clearly relating to the physician associates we've talked quite a lot about, as it happens, but patients realizing that when they saw someone who didn't have a full range of skills or hadn't seen the problem before, they might just say, well, you stay there, I'll go and get someone and talk to them. The knock-on effect of that, of course, is there has to be someone for them to go and talk to. Is that going to happen then, or is it going to be another appointment? And clearly these have consequences for workload for other people as well. So if we go back to the questions that we started with and say, what about the working practices? Accurate matching of patients' problems with practitioners' competencies, accreditations, and experience is certainly challenging in general practice. It's quite difficult to capture, to update, and to apply those listed competencies. Practices tried it with pieces of paper, skill matrices, as they sometimes call them, to try to help the reception staff to understand what different practitioners could do. But it easily went out of date when people went on courses and staff changed. The workarounds that were talked about often required GP attention. They were needed to resolve the limitations on what practitioners can independently do and to provide that supervision and support that we've talked about. And these working practices may account for why much of their work is not characterized by substitution or complementary work. There was just so much of kind of task shifting, if you like, and requiring double attention and so much of that at the time. When we think then about how patient experience changes with increasing skill mix, clearly the employment of new practitioners creates that additional work for patients. Understanding the new roles, what can they do, what can they not do, building relationships and that loss of an established trusted relationship and continuity. And also actions can be taken to facilitate and improve this by better communication and more visible GP supervision that is sometimes required. So really, in a nutshell, it is a new game that we're playing in general practice. It hasn't worked out really well for everybody. I think it's important to remember that this was quite early days for some of these practitioners, and so it will be interesting to see how things develop. But actually the fact that we noticed that some things were actively worse, particularly for patients, I think is important, because something clearly needs to be done in order to build their confidence so that they know how best to use the practitioners that are available to them in practice. We've got some references. We can share those with anyone who wants them. And really, thank you very much for listening, and happy to take some questions.
Thanks very much, Sharon and Igor. Yes, we can check the chat box if there are any questions, or you can use raise your hand if you can see the icon at the bottom of your screen, and use the microphone, please. In the meanwhile, I can start with a question myself, if I'm allowed. I think it's obviously it's very interesting to have this insight into how practices have changed recently, and in particular the qualitative data there, trying to explain a bit more of the interactions and how it is, what the experience is for patients and the experience is for this diverse workforce. Now, I wonder if you see any sort of instances of complementarity between the work of a GP and any of the practitioners that you have mentioned, any other of the roles. Because if I understood it well, you seem to have identified some independent processes where you can see some increase or decrease in terms of some quality indicators that you mentioned. Do you see any complementary work that seems to work well, positively?
Do you want to take that first, Igor?
Yeah, so I mean, my answer here will be probably short, because on the outcome that we looked at, there was pretty much no evidence of complementarity on the outcomes. Although this doesn't mean that there is no complementarity in the actual day-to-day work, but we are looking only at the final outcome, and there doesn't seem to be that much of a complementary or substitution on that. The only thing that was somewhat interesting and somewhat meaningful too was that on the cost side of things, we found that adding nurses to a GP practice, everything else equal, makes the work of a GP slightly less expensive. So that on the cost side looks like the working relationship between GPs and nurses seems to be more established, and therefore they seem to be together more efficient. That's the only thing that we found on the quant side, but I'm pretty sure Sharon will have more interesting insights on the qualitative side of things.
Thanks. When you see people working together and they're working with the same patient group and they're seeing the same patients, you would think that by seeing one person, they might not need to see another. And that seems totally logical. And up to a point, it's probably the case. But my question, I can't answer my own question really as to whether if they see person one who can progress the understanding of their problem to a certain degree, but then has to do something else. We don't yet know whether that really reduces the workload or not. The only evidence that we have, which wasn't actually in Igor's paper, we looked at data from the work-life survey that is carried out sequentially on GPs, has been undertaken for a number of years. And when we asked GPs about their workload and looked at that in relation to the people employed in their practice, we found that it was only if they had more GPs did the total workload of each GP seem to drop. So what we're thinking from what we're seeing and from these is that there's so much supervision, and possibly you also need to see kind of actions going on, that actually it's taking a lot of the GP's time to support the other staff who are there, to make sure that the things that are more complex that they need to see are also seen. And it really doesn't seem to really lighten their workload, or unfortunately to make them any more likely to stay in the job for longer, which of course is a huge problem at the moment.
Certainly. Thank you very much. I think in the chat we had another question from Sophie. It says, how do professionals from different groups coordinate care for a patient in relation to them having multiple problems and continuity of care?
Yeah, a very, very good question. And it happens differently in different places, to be fair. The practice nurses have for many years done a lot of the QOF work, which is monitoring long-term conditions and so on. And some of them have upskilled to a huge degree in, for example, the management of diabetes. So all their diabetic problems can be kind of encapsulated in one appointment with the nurse for reviews or whatever. But they may have other problems, and often the same nurse is not skilled up in the same way across the board, and that's partly where the problem comes in, I think, because traditionally GPs have been expected to have sufficient broad knowledge to deal with pretty much everything that comes in, and anything that they couldn't themselves deal with, they're expected then to refer, and they understand the hospital system well enough to be able to do that. But people who have trained in a different way from a different discipline, often their training has been that bit more narrow. So yes, they're really, really good at what they do, but they don't really have that breadth of knowledge across the system, whether it's in community care or in hospitals, sometimes to actually support all of the different problems that patients have. And I think that is something that is really difficult to do. I mean, it's difficult to do anyway, because access is just such a problem at the moment. But yeah, when there are multiple problems, it's very difficult. And you know, you need a generalist to deal with those things.
If I could just add on this, I have no smart thing to say about how it works, but what I can say is that one potentially interesting data source to explore this more in detail from a quantitative perspective is the GP appointment data, which should at some point become available also to researchers. And that could give an insight on how that works.
Okay. Yes, please, Julie.
Just sharing video. Hi, I'm Julie McLaren, and I'm the new head of nursing at London Met. And we are planning our upcoming curriculum to have much more of a primary and social care focus, rather than being traditionally hospital-led. And one of the things that we're doing is trying to get more students out into practice. And I wonder if you'd had any thoughts around kind of where students fit in your equations. You've talked a little about the introduction and training and support of people going into what I believe might be first contact practitioner roles, but we've always had a lot of pushback from GP surgeries and primary care teams about getting student nurses into that realm, really. And with certainly in the Islington and surrounding areas, landscape, we're very short now on GP nurses, advanced practice nurses, basically any sort of nurses in primary care. So I wonder if you had any thoughts around that.
I don't think I've got any hugely helpful thoughts around it. It is very difficult if you're trying to deliver a service under pressure and deliver training at the same time. Practices clearly do it. They have GP trainees. The aim for a training practice usually is to try to be kind of time neutral, if you like, over the period of training that trainee is there. So you know, at the beginning they're going to not do very much work, you might say, and have a lot of support, but later towards the end, once they're near, then they should be relatively competent to do a lot of the work for themselves. I think it's difficult for me to know nursing well enough, in fairness, to really understand what nurses need in that role, if you like. I think probably sitting down with practice nurses and working out where they see that the practice nurse trainee could fit. What sort of models would work for them? Is it because you want more than an observing model? You want them to be able to do things, because that's why they're there. That's what they want to do with their training time as much as their working time. So I think it probably needs a bit of grassroots kind of communication, conversation to try and work out what would work. I would have thought that most practices, providing it is cost neutral, time neutral, and so on, then they probably would be very supportive of it. But you know, I can't speak for people.
I think we're very lucky with our local GP federation, who is really on board with it. But it kind of makes me. I think your presentation has given me a much better understanding of some of the other pressures, or that GPs and the nurses working within primary care might face. And just to note that certainly in the School of Human Sciences, we're currently involved in a project with our local partners, looking at training for first contact practitioners. And we've got a group of pharmacists and physios, I think, at the moment, who meet with us on a monthly basis, just to explore practice issues with our team of dietitians, physios, nurses, and that appears to be having a good effect back in practice. So it's more of a reflective, supportive group.
Sounds good. A lot of the problem in general practice at the minute is that people just don't have a lot of headspace, which doesn't help anyone. But somehow we've got to find a way forward.
Yeah. Thank you.
Thank you, Judy. There's a question from Nikki as well. It says, did you get a feel as to whether the employment model impacted on satisfaction or effectiveness? For example, an embedded practitioner versus a shared practitioner on a seasonal basis across multiple practices.
That's an area that we're now looking at with another study. Obviously, the ARS funding that has now come into place and is being used a lot creates a very different working environment. People are employed often out with the practices in which they're working. They're often working across 2, 3 or more practices. And we are now talking to some of those workers about how that is and how that works. And there's also part of the team is looking at the quants data as well to see what the outcomes are. So yeah, it's one of those things that the findings that you want are always a little bit later than you want to know about them.
Thank you. I do have another question while we wait for more questions from the audience. Recently, I did this year actually. I did an evaluation for the NHS in North Central London about the winter campaign, and one of the things that we need to analyse were the new roles on GP practices, because there was an impetus to direct people to GP practices instead of accident and emergencies, and what we found there we run also quantitative and interviews with people here in North Central London, is that they didn't know much about these new roles. Part of the campaign was to inform people of these new practitioners, and you might have seen that I suppose in your area too, coming from the NHS, these posters with all the different roles and saying that they are available and so on. And the second point was that, well, something that probably I'm not sure if you experienced at that time in your area, although you run for so many practices across England, which is a digital type of appointment, remote appointment. Probably they were starting, but certainly during the pandemic, it became the norm. And both processes or situations in these primary care settings, in interviews, we found that people decided to attend accident and emergencies because they thought that, obviously, at least they say, I'm going to see more likely a GP there. than if I need to wait for the appointment, if I need to do it online or do it by telephone. Well, it's a long story, that one, but I don't know if you saw any of what it is now called the unnecessary clinical attendance to accident and emergency as a byproduct of this study.
Igor, do you want to come in there?
Yes. So on this very last question, I don't think there was ever an idea of looking at avoidable attendances in ED in relation to this work. But I can with fair confidence say that the quantitative evidence so far in relation to strategies based on shifting demand from the emergency department to GP practices is, yeah, I'd say pretty clearly pointing to the direction of there doesn't seem to be that much of an effect. So it's not working for some reason, and the reason seems to be, as you just mentioned, also from large-scale quantitative studies, that people feel safer going to the A&E because they know they will be seen by someone, whereas in primary care, you never know how quickly you can be seen and who will see you, essentially. But it was all unrelated to the skill mix work, although it's a good point, I think, to take forward.
Thank you.
I think going forward, it's going to be possibly quite difficult to unpick some of the separate issues that have been going on in the last few years, because clearly general practice was under a lot of pressure even before the pandemic came. Once that happened, everything was up in the air, and very few people were seeing GPs or any practitioners in practice face to face. But now it's kind of returned to, I'm told, something like 70% of appointments are face to face. And also there are some patients who feel that actually for the particular problem they've got, speaking to someone on the phone is absolutely all they need. So I think this is a much more nuanced picture, you know, to think that face-to-face has to be best. Sometimes it's absolutely necessary. Having worked in both systems, I can say as a practitioner that actually it's much more satisfying to see someone face to face, and you feel like you can get a much better idea of what's going on for them, and you can have conversations with that I think are much more difficult to have if you have absolutely no previous clinical contact with them. You don't know what sort of person they are, what their health beliefs might be, for example, or their general attitude towards health and medicines. So it's a very nuanced picture, and yes, of course, there are lots of people working on it. But the period in which everything was disrupted by the pandemic has been so different for patients, practitioners, A&E departments, everybody, that it'll be interesting to see what if anything we can really learn from it for the future.
Thank you. Yeah. So is there any more questions or comments we can take from the audience?
I'm wondering if any of the audience have got any experience of this that they might like to share.
You can use the chat box if you prefer. Okay. Okay, well, Julie, please.
just wondered kind of what the next steps or the next stages of research that you are involved in. Are you looking at a post-pandemic landscape and planning any research in that?
The study that well, I'm involved in a couple of studies, but one of them is looking at the Rs workers, the Rs funded workers, and there's a team that's working on all the figures in a similar way to what Igor has talked about today, but lots of different analyses. And myself and a colleague are talking to people who are clinical directors, practice managers, and also to practitioners who work as Rs funded staff, about their experiences and how it's working for them. So yeah, we think that will be really interesting. We're clearly fully involved in it at the moment, so we don't have any findings to share just yet. But that's certainly a study that we're very involved in at the moment, and it is largely post-pandemic because people are now thinking kind of the way we are working now, the way we are likely to be working in the future.
Thank
Yes,
you.
in
That's
relation
really
to
important.
oh, sorry, go ahead.
No, you go ahead, Igor.
Just to say, yeah, in relation to PCNs, there's going to be some work coming out at some point in the future, which will also relate to skill mix somewhat.
And what about the transfer from PCNs into integrated care boards? How is that integration helping or not helping the situation? Is that going to be focused in some of your work?
We have certainly got colleagues who are definitely looking at that sort of area. I think it's still pretty early days though.
Yeah, definitely on the ICBs, definitely. What we have ongoing, again, hopefully sometime soon will come out, is work looking at sort of a problem with integration, but in relation to how PCNs cut across different GP federations or different healthcare homes. So we have a little piece of quantitative work looking at that, which is not related to the integrated care boards, but I mean, looking at that type of integration problem.
Brilliant, thank you.
So there's a question from IB, says, is there any research about how the practices that had more skill mix coped with the pandemic compared to those low skill mix?
I'm not aware of any detailed work on that. We did just for completeness go back and speak to people about it, but I wouldn't say it was in depth enough to make any generalized comments about it. People worked in lots and lots of different ways in different places, and some of we do have colleagues who've been looking at PCNs right through the time, and we'll have stories about that coming out from some of their research, but I haven't seen it published yet.
Okay. Okay, but probably these are the questions. Okay, so thank you very, very much.